Good afternoon, everyone. Welcome, and thank you very much for joining us today. So I think we can start.
Perfect. Thank you, everybody. I'm Ric Arseneau, and I have my physician assistant here. This is Chewbacca, and so he will be listening in. And so today we're going to talk about long COVID disability benefit supports. And this is really one of my, what's the word that I want to use? One of my passions. Because in our clinic, there are 78% of patients who are unable to work. And one thing that we know for sure is that if you have housing, food, or financial insecurity, it's hard to focus on your illness. So I'm the medical director of the BC Center for Long COVID, ME, CFS, and Fibromyalgia. So for those of you who are unfamiliar with the acronyms, it's myalgic encephalomyelitis and chronic fatigue syndrome. I'm a clinical professor and division member in general internal medicine at St. Paul's Hospital and University of British Columbia. So before we start, we need to talk about why it's so hard to get disability. And a big part of that has to do with making a diagnosis. Are you raising your hand, Adriana?
Yes, sorry, Rick, to interrupt. Just very quickly for everyone attending, we will have time for Q&A at the end of both presentations. We have Dr. Ric Arseneau, and then we have Disability Alliance of Canada joining us today. So we will have time for Q&A at the end of the webinar. So if anything comes up, just feel free to write it down in the chat or write it on a piece of paper, and then we'll go through the questions at the end. Thank you. Sorry, Rick, go ahead.
Well, thank you, Adriana. So this is an invisible condition, and I've been taking care of patients with these conditions for over 30 years. At last count, I've seen over 10,000 patients. And so I've listened to a lot of stories of gaslighting, of not being believed. And that's especially difficult when somebody has the power to give you money or withhold it. So before we start, this is going to be weird to many of you. We have to talk about what long COVID is because you may or may not know. Nobody agrees. So there is no definition of long COVID that is agreed upon. At the beginning of the pandemic, my partner and I were in Mexico, and we had just they just had announced the pandemic and the outbreak. And I commented, I said, "Oh, we're going to see a shitload of patients with post-viral syndromes come up. I expect about 10% of patients with COVID to get a post-viral syndrome." And so I was really confused when in the news there's, "What is this long COVID? We've never seen this before. We don't understand this." Of course, we understand it. We've seen it for 30 years more, and we know exactly what it is. And so, how did I know that 10% of people were going to be affected? It's not because I'm smart, it's because this is the initial paper from Dubbo in Australia, and this is from their infectious disease clinic. And they looked at patients coming into their clinic, and 11% at 6 months were diagnosed with chronic fatigue syndrome. And it didn't matter which infection they presented with. And so we knew that 10% of people would get a post-viral syndrome. Took about a year, but now we know 10% of people in the initial pass got post-viral syndrome. If you're vaccinated, now the chance is, now with the new virus, the chance is 7%. And if you're vaccinated, the chance is 3.5%. So the numbers don't seem horrible, but whenever you get hundreds of millions of people that are affected, you're going to see huge numbers. And it's confusing because patients are going to present with over 200 different symptoms. But for those of us in the know, we know that those symptoms can be categorized into fatigue, pain, brain fog, sleep disturbance, and unexplained symptoms. And the unexplained symptoms can be any system, but they tend to focus on the gut, the brain, and the autonomic nervous system. To make things even more confusing, is that these conditions rarely occur in isolation. They're part of a family of conditions called central sensitivity syndromes. And you can see the list here: fibromyalgia, myofascial pain, tension, headaches, IBS, POTS, a whole bunch of others. And this doesn't include two comorbid conditions that are commonly associated that are not central sensitivity syndromes: mast cell activation syndrome and hypermobility. And so, one thing that we knew at the beginning of the pandemic is hypermobile patients are going to get a post-viral syndromes more likely. Last year, somebody finally reported that, hey, post patients are more likely to get long COVID if they're hypermobile. So in our clinic, the average is 5 to 6. And one of the things that I've predicted, and it's certainly true in our clinic, is that if you already have pre-existing migraines, IBS, PTSD, POTS, you are more likely to get what we call long COVID because you're predisposed. Haven't seen that in the literature yet, but I can tell you in our clinic, it's unusual for me to see a patient presenting with one thing. So let's talk about the name, because the name has caused a lot of problems. Long haul COVID, post-COVID conditions, post-acute sequelae of COVID, and now post-acute infection syndrome, PAIS. And the problem is that people use these interchangeably to mean the same thing. So I'm not saying I have the right definition, but what I'm saying is you have to understand the problems with the definition so that when you're reading something, you know who you're talking about. And so right now we take an approach very similar to the Mayo Clinic, because the Mayo Clinic says that long COVID and post-acute sequelae of COVID are not the same thing. That PASC, post-acute sequelae of COVID, or what now is called PCC, post-COVID conditions, has three groups: people with tissue damage, people with no identifiable tissue damage, and people who develop psychiatric psychological conditions. This is what they call long COVID, the post-viral syndromes, the ones that fit in the category of central sensitivity syndrome. We've expanded that a little bit, and we think that these conditions should be based on what we call phenotype. What does COVID cause? And so in our mind, there are 5 things that COVID can cause. And you'll be familiar with all of them. So the first are the people who get tissue damage or inflammation. Those are the people who get lung scarring. DVT is blood clots. Loss of taste and smell is anosmia, myocarditis. And then you get people who get triggering of autoimmune diseases like rheumatoid arthritis, lupus, inflammatory bowel disease, Sjogren's, hair loss, and vitiligo, pigment loss. You get people who develop or accelerate metabolic diseases. And what that means is some people for the first time will develop diabetes, hypertension, high cholesterol, and they will be accelerated, which means if you have those pre-existings, you will get closer and quicker to a heart attack and a stroke than if you didn't have COVID. There's the group that was already identified, the psychiatric psychological. People can develop depression, anxiety, PTSD. And then there's long COVID, so the reality is we didn't need the name long COVID, and it has added a shitload of confusion. And so we think the baby finger should be called long COVID. Some people think the hand should be called long COVID and that it should be interchangeable with PCC. And I'll argue that part of the reason that we haven't found any treatments is if you include all these people together, nothing is going to work. So here's an example from my clinic that caused an uproar. So it said prevalence of symptoms, comorbidities, fibrin amyloid microclots in long COVID, PASC. So all my patients are coming to me. Do I have microclots? Do I need to be treated for microclots? Well, are these the patients who have post-viral syndromes, or are these the patients who have tissue damage and inflammation? This study did not make a distinction. And so the answer is we don't know. So the problem right now is that people are fighting over the definition, and they're looking in the wrong direction. Instead of saying, let's categorize people into what happened to them, what are the phenotypes, they argue about how long it should be. And that's a problem too, because if you, this is current definition, I just downloaded this today, it hasn't changed. It's 3 months. If you use 3 months as your definition, it's going to have very different implications for prognosis. So people who have it at 3 months, 4 months are actually more likely to get better. So if you read prognosis studies and they have used this definition, it doesn't apply to you if you have a post-viral syndrome. The other thing is that this doesn't tell you if you're going to have a post-viral illness. It just tells you that you have symptoms in any one of those 5 categories. The other thing sorry, this slide is an error. It's a copy paste. It should say implications for not prognosis, but well, yes, for prognosis. Because, so for instance, one of my colleagues, very well respected, was on the news through you guys this week, and she made a statement that's true and not true. She said that the severity of your initial COVID infection determines whether or not you're likely to get long COVID. That's only true if you include the 5 categories. That almost all of the patients in our clinic who develop a post-viral syndrome had a mild disease. Out of over 1,000 patients, we've had maybe 3 or 4 who were hospitalized and went to the ICU. So if you don't know who you're talking about and you don't know what the definition is, everything that you read, you have to read with a knowledge, how are they defining this and who are they talking about? Because it might not be you. So we're going to talk about long COVID as a post-viral syndrome because that's who our clinic sees. So we don't accept patients with any of the other 4 categories. Well, there's overlap, right? People can get, so we often see patients who get tissue damage, loss of taste and smell, and a post-viral syndrome, chronic fatigue syndrome. But in our patients who have chronic fatigue syndrome for other reasons, we don't see loss of taste and smell. So the problem with a syndrome is that you're in or you're out. You either have it or you don't have it. You fulfill criteria, you don't. And the reality is that post-viral syndromes exist along a spectrum. At the mild end, you're going to have young adults who have mono or who have and are out of commission for 6 months to a year. At the higher end, you're going to have people who develop chronic fatigue, fibromyalgia, and other conditions. And in between, you're going to have people like me. I got COVID. I'm not completely recovered. I'm about 60 to 70% back to normal. And I have severe orthostatic intolerance, but no change in heart rate or blood pressure, which means I fulfill criteria for nothing, despite the fact that I'm severely affected. Luckily, my work allows me to work from bed in the afternoons, and so I'm fully functional, productive wise. But you can imagine if I tried to get insurance looking as good as I do, you look normal, you're able to stand up, that it would be tough. And so people will ask me, are COVID and chronic fatigue, long COVID and chronic fatigue syndrome the same thing? Well, no, because chronic fatigue syndrome has many precipitants. For some people, it's physical, like a car accident, or psychological, like PTSD, or an infection, and not necessarily virus. So only a subgroup of patients who develop chronic fatigue syndrome are post-viral. The other problem is that patients with post-viral syndromes don't only develop chronic fatigue, they can develop fibromyalgia, postural orthostatic tachycardia syndrome, mast cell activation syndrome, irritable bowel syndrome, migraines, others in that list of central sensitivity syndromes. So yes, a post-viral syndrome includes all of these, but if we look at the overlap, chronic fatigue syndrome is caused by all of these things. So what's the overlap between chronic fatigue and fibromyalgia? And long COVID is that a proportion of patients with long COVID will get chronic fatigue or fibromyalgia as their post-viral syndrome, but it's not the same as chronic fatigue syndrome. It's one of the subsets. So let's look at the problems with applying for insurance because you look good. And trying to convince somebody that you're ill when you look good is tough. So the first reason that they have challenges is a lot of patients don't have a diagnosis. They might not even know why they're sick, and their physician may not know as well. The second is what kind of long COVID do they have? Do they have a post-COVID condition, or do they have long COVID, a post-viral syndrome? It's easier to get the insurance in the post-COVID conditions because there are tests that are abnormal. Whereas in the long COVID, the way we define it, the post-viral syndrome, there are not. So there's no single definitive tests. And yesterday I wrote the first appeal for our clinic that was denied by Canada Pension Plan because we have a 100% success rate in appealing LTD, CPP, DTC, but not WorkSafe BC. And I will say this publicly, WorkSafe BC is an unethical organization. You cannot sue them. And so they do what they want. And so I've written a second appeal, and this is the first time we've had to write a second appeal. And the clinician who saw them obviously has no clue about these conditions because he's saying all the tests were normal, blah, blah, blah. So I had a fun time getting all my frustrations out in writing this really nasty letter. So no test, symptoms are invisible, and the disability fluctuates. And sometimes it fluctuates, it's enough that you'll even gaslight yourself. Am I really sick? I'm having a good day. I don't want to be sick. The symptoms are hard to measure. So this was again in the letter yesterday of denial, that they did a functional assessment and a cognitive assessment in this patient, not realizing that functional assessment is invalid in this patient population and cognitive assessment is invalid, even a formal neuropsychiatric test. And so I had all my references, and so it says this, so I'll be able to rebut that. The other problem, and this happens especially when you're applying for disability tax credit and the patient wants to go backwards, but they don't have the same family doctor, is that the family doctor often just records a diagnosis, but not your functional limitations, which means that the doctor's notes are not very helpful at backdating. What we do, if it's the same family doctor, we send the family doctor a letter that says, I attest that this patient has been this disabled for X number of years. And we use that. But the notes are not helpful because they document a diagnosis, and the diagnosis does not give you disability. It's the degree of functional limitation. There's also stigma and misunderstanding. There's a study that looked at what is the biggest implication on society of long COVID. And the result, long COVID amnesia. People don't want to hear about it. They don't care. They're tired. And so a lot of people try and tell you, and even your doctors, that it doesn't exist. The other problem is that the forms are not designed to capture your degree of disability. And that's why often when they say, can she do a backflip? Can he do a pirouette? Can he lift his hands above his shoulders? I put a big X through that because that does not capture disability. What I will say instead is the patient can do most physical and cognitive uh, tasks, but only for brief periods before needing to rest or causing post-exertional malaise lasting 1 to several days and worsening of symptoms. So there's a lot of barriers, but the thing I will tell you is push, push, push. We have successfully appealed 351, and that was 6 months ago, so it's probably a lot more since then. We've also gotten disability payments for hundreds and hundreds of patients, DTC, CPP, and like I said, this will be the first time that an appeal will be denied. So most of the time, our notes are good enough. 10% of the time, we have to write a nasty letter, and 1% of the time, we have to include a lawyer. And the lawyer that we have is one of our patients, and she has a video on our website that describes the legal implications of these conditions. So we have lots of online resources. Those of you who don't live in British Columbia and can't be referred to me, I suggest that you go to our website and you click on Resources and Primary Care Toolkit. You'll be able to download the diagnostic criteria for these conditions and the checklist of central sensitivity syndromes. And you'll be able to bring it to your physician. So at least if you don't have a diagnosis, you can get a diagnosis when you apply. Also, we have a YouTube channel called METV, not Me TV. It's ME for myalgic encephalomyelitis. We've got lots of great videos to help you understand these conditions, including some of the other post-viral syndromes. I went way too long, Adriana. I am sorry.
Thank you so very much, Rick. Very valuable information. Thank you. Um, Once again, it's we will be taking questions at the end, so I'm going to give the host to Brooklyn from Disability Alliance.
And so I'm going to apologize, but I'm going to turn off my camera so I can lie down due to my orthostatic intolerance.
Thank you, Rick. Brooklyn, go ahead.
Okay, thank you so much. I will go ahead and share my screen. Thank you so much for that wonderful presentation, Rick. I'm joined today by my colleague Eliza, and I'll pull up her slides and we can get started.
Oh, I can get it too, if that's okay.
Oh, I've just been made the host, so just let me know when you need a transition.
Okay. Let's see.
All right,
Am I
Camille.
sharing right now, or are you?
I am.
Oh, okay. Sorry about that. Okay, come back. All right, 1 second. Okay. Okay, I should be good to go. Thank you so much for holding on, Brooklyn.
Of
So,
course.
hi everyone. Thank you so much for showing up today to hear Brooklyn, my colleague, and I talk to you about disability benefits. I'll start off with an overview of CPPD, but first I want to introduce myself and our organization. Go ahead, Brooklyn. So my name's Eliza. I don't think you can see me. I think you can see Brooklyn, so I'll describe myself. I'm a white person in my late 20s with shaggy brown hair, and I'm especially excited to be presenting for the Canadian COVID Society as a fellow masker. I joined DAC, Disability Alliance Canada, just this last June. DAC is a new nonprofit organization founded just last year, but it came out of Disability Alliance BC, which has been around since 1977. Our mission is to promote a more inclusive and equitable society for people with all disabilities through direct services, community partnerships, systemic advocacy, research, and publications. Oh, you can see me. Thanks for letting me know. So DAC serves all of what is colonially known as Canada, but is based on the traditional, ancestral, and stolen lands of the Musqueam, Squamish, and Tsleil-Waututh nations, who have stewarded these lands since time immemorial. However, I live and work from a Treaty 20 Mississauga territory in the traditional territory of the Mississauga and Chippewa nations, collectively known as the Williams Treaty First Nations, which include Curve Lake, Hiawatha, Alderville, Skugog Island, Rama, Beausoleil, and Georgina Island First Nations. I'm personally of Scottish, Irish, English, German, Polish, and Ukrainian ancestry, and I have ancestors who came to this land as recently as 70 years ago, as well as ancestors who came to this land as far back as 250 years ago. And I respectfully acknowledge that the Williams Treaty's First Nations are the stewards and caretakers of these lands and waters in perpetuity, and that they continue to maintain this responsibility to ensure their health and integrity for generations to come. Okay, next slide. So today we'll be going over the Canada Pension Plan Disability, also known as CPPD. So what is CPPD? Before we dive into it, I'd like to preface that CPP disability is a very, very complex program. So I've done my best to condense the most important information here. However, there's a lot of nuance to every individual person's situation, but this will hopefully lay a strong groundwork for figuring out if it's the right benefit for you and how to increase your chances of success. Next slide, please. Oh, I think you already did. So when someone asks the question, what is CPP disability? Here's what I tell them. Number one, it's a federal program, meaning that it is provided by the Government of Canada and is administered via Service Canada. Number 2, it's a contributory plan, meaning that a person would have had to have paid into it to receive the benefits. It can be helpful to think of it as a type of insurance. Number 3, the reason someone would apply for CPPD is for the monthly payments. So some other disability benefits provide additional perks like transportation passes or assistance with medical costs, but CPPD is just a monthly check. And number 4, the program is designed for people who are unable to do any kind of work. However, there is some wiggle room there that we'll get into later on. Next slide, please. Oh, I think we did that one already. Next one. Here we go. Okay. So the amount that a person gets varies for everyone, and it's calculated based on the amount you contributed to your CPP while working. So the amount goes up a little bit each year to help with inflation, but the minimum amount that you'll get for 2026 is just a little over $600, while the maximum amount is $1,741. But Service Canada reports that the average for a person new to the program is getting about $1,190 each month. I'll also note that being on CPPD does not lower the amount that you will receive once you retire. In fact, it usually bumps it up a little due to how things are calculated. So on top of this monthly amount, if you have children under 18 in your care, you'll get an additional $300-ish per child each month. And if you have a child who's not in your care, then that amount will go to the child's caregiver. Also, if your child is between 18 and 25 and they're studying full-time at an accredited school, then they themselves will receive the check. But if they're in part-time school, then they'll get about $150 instead. People also often ask about retroactive payments. If you get approved, you can expect to receive back pay to the date Service Canada received your application. It is possible to get paid for a period before that date, usually up to a year, but it's something you don't have much control over, and I tell people not to rely on it happening, but it's a nice bonus if it does. Next slide, please. Okay, so we now know what you'll get from being on CPPD, but how does Service Canada decide who to give it to? Next slide again. There are 3 hurdles to clear before you can be approved. The first is mostly straightforward, but the other 2 will need more explanation. So number 1 is that the person must be between 18 and 65 years old, and people over 60 must not have been on CPP early retirement for more than 15 months. If that is the case, they're considered for a very similar benefit called the CPP post-retirement disability benefit. Number 2 is that the person must have a severe and prolonged disability. Severe and prolonged are important to define and will be explained a little in the next couple of slides. Number 3 is that they must have made the required number of contributions to their Canada pension plan. This part is the most complex, and I'll be spending a good deal of today breaking that down. Next slide, please. So when Service Canada is determining if your disability qualifies, they first look at if they consider your conditions to be severe. So the legislation defines a severe disability as any condition that would make a person incapable of regularly pursuing any substantially gainful occupation. So a substantially gainful occupation is one that would pay more than the yearly maximum amount that a person would get from CPPD. For 2026, that amount is about $21,000. So it's important to know that most people working any job are likely to be denied initially, but people working low hours and receiving significant accommodations could be successful in later stages. Next slide, please. So next, I'll look at if your condition is considered prolonged. Prolonged is defined as a disability that is likely to be continued and of indefinite duration or is likely to result in death. Basically, the CPP disability benefit won't go to someone that is likely to recover from their condition to the point that they can return to substantially gainful work. Next slide, please. So you've made sure that you meet the age requirements and have a severe and prolonged disability. How do you know if you meet the contribution requirements? So Service Canada judges if you made the requirements using something called the minimum qualifying period, or MQP for short. Next slide, please. So an MQP is the minimum period of time that a person must have worked and paid into CPP before they become disabled. By the end of this time, the applicant has to be able to show that they have a disability that is severe and prolonged. In most cases, a person would have had to have worked and paid into the plan for at least 4 out of 6 years and be able to show that they became disabled by the end of their most recent 4-year or out of 6-year period. So it is possible to instead only need 3 out of 6 years, but that's for people who had worked for 25 years or more. There are also other calculations if you stopped work prior to 1998, but that's extremely rare nowadays. Next slide, please. The way you can see which years you paid into your CPP is by looking at your statement of contributions. The easiest way to find your personal statement is to go online and find it in your My Service Canada account. Otherwise, you can call Service Canada and request it to be sent to you by mail. So once you see your statement, how do you know which years count towards meeting your MQP? The minimum you would have needed to earn from employment income to have that year count, also called the Disability Basic Exemption or DBE for 2026, is $7,400. This amount goes up yearly, so every previous year will be a bit lower. The way you find out the amount from past years is that the DBE is calculated at around 10% of the yearly maximum pensionable earnings, which for 2026 is $74,600. I've included a link on this slide that you'll be able to access after the presentation to the list of yearly maximums to count all prior years. But put simply, if you're over $7,400, you're probably good to count it. Next slide, please. Since this concept can be a bit tricky, let's look at a few examples of finding the MQP. So all of these scenarios are looking at the years from 2021 to 2026. In example A, we have contributions in all years except for 2022 and 2025. That gives them 4 out of 6 years, which means they would have to show they became disabled by the end of 2026. In example B, the person only has contributions for 2024 to 2026. This person with only 3 years of contributions would not have a valid MQP unless they had a total of 25 or more years of contributions. I also included example C, which has a person contributing for all 6 years from 2021 to 2026 to show that MQPs can be extended into the future. So since they have 4 years of contributions from 2023 to 2026, their 6-year period would end in the future in 2028. This can be very helpful because Service Canada highly values the medical documentation within your MQP, so this person would have additional time to coordinate with their doctor to prepare evidence to support their case, such as nose tests, etc. Next slide, please. So if you're in a situation where you've looked at your yearly contributions and haven't been able to meet your MQP, don't give up just yet. There are a number of exceptions that Service Canada allows for called provisions that may help you out. Some of these are automatically applied, while others you'll need to provide some information in your application. So let's see what to look for. Next slide, please. So the first one is for people who have stopped working or dramatically reduced their work hours to care for children. When they fill out the application, they can apply for the child rearing dropout provision. This allows the primary caregiver to pull out the years where they were caring for a child under the age of 7, treating those years as if they don't exist, which can extend their MQP window. The next one is a credit split. This is for people who have never worked or had low earnings while their ex had high earnings. This will combine and split the contributions made by the couple during the time that they lived together. And then there's the International Social Security Agreement. For people who have worked in another country, that country may have a Social Security agreement with Canada, which could allow them to transfer their contributions from that country into CPP contributions. I've included a link to a list of all of the countries who have that agreement with Canada. If they paid into the Quebec pension plan, those can also be combined with CPP contributions. There's also something called the proration provision. So if someone stopped working early in the last year that would have helped them meet their MQP, then they can use the proration provision to bring down the amount they need to make for that year to count. Next slide, please. So we won't have time to go over the whole application form today, but if you think that you qualify and would like to apply for CPPD, please reach out to Disability Alliance Canada for assistance. We can also provide some support with appeals if you have been denied as well. Next slide, please. So that's all for CPPD. Thanks so much for listening, and I'll pass it on to Brooklyn to tell you all about the disability tax credit.
All right. Thank you very much, Eliza. And I'm just going to finish off our presentation for today talking about the disability tax credit. I will do my best to keep it brief as I understand this is a lot of information to take in today. So we're just going to talk a bit about what the disability tax credit is and how Disability Alliance Canada as an organization can help you access it. So just in a little agenda for today, we're going to talk about what the disability tax credit is and why you might be eligible, and our services, including working with an advocate, self-directed supports, and our options around working with a support person, and then we're going to be good to go forward with a Q&A. So the DTC is a non-refundable tax credit, meaning it can help reduce the amount of income tax owed by a person with a disability or their supporting family members. As Dr. Arseneau has already mentioned, many folks with the long COVID spectrum of disorders are unable to work, but if you do have supportive family, whether that's a spouse, parents, siblings who provide you with financial support, they can claim a deduction on their taxes for supporting you, and that just frees up further funds to go towards you and your care. The credit can be applied retroactively for up to 10 years of income tax filing. So if you've been struggling since the beginning of the pandemic back in 2020, you can still recoup losses from that time. Just because it's a little bit later doesn't mean you're losing out on any money. So a person can qualify for the disability tax credit if they have what's considered residential ties to Canada for tax filing purposes, meaning you don't need to be a citizen. You don't even need to be a permanent resident. If you are a temporary resident, like a post-secondary student, temporary foreign worker, as long as you're filing taxes in Canada, and then you could potentially be eligible based on residency. You also need to have a valid social insurance number and have a severe or prolonged physical or mental impairment. But what does that mean? So, a prolonged impairment means the impairment has lasted or is expected to last for a continuous period of 12 months. As we know from Dr. Arseneau's presentation, that's likely going to be the case for folks with ME/CFS, fibromyalgia, any of the central sensitivity syndromes brought on post-viral from COVID. So what makes something severe? There are a few ways for a restriction to be severe. A person can be considered markedly restricted in an activity of daily life, but that's just a synonym. What that essentially means is it has to take you at least 3 times as long as someone with no disabilities of your own age to perform some basic activity of daily life. Or if you are experiencing limitations in multiple areas, it needs to take you at least twice as long to perform certain day-to-day life activities. Or if you are unable to perform certain day-to-day life activities, that also counts as a severe restriction. So what are the categories we can qualify under? Vision, that's generally to qualify under vision alone, a person needs to be legally blind and their vision cannot be correctable with glasses. But the CRA will also consider some conditions as sort of significant limitations in vision other than blindness. That can be things like migraines with aura, vertigo, hearing. It is similar. Generally, they're talking about hearing loss, but conditions like tinnitus can also count. Speaking, the cognitive fatigue that comes with speaking in ME/CFS long COVID can be relevant here. Walking, they're asking about walking a short distance, like a city block, which is about 100 meters. I know for many folks experiencing post-exertional malaise, that might not always be doable, although it may sometimes. And even restrictions that are variable are worth talking about in this process. Eliminating, that is bowel and bladder functions, so using the toilet. Feeding includes the act of physically eating and the act of preparing food. So if you're someone who struggles to stand for long periods of time or carry heavy objects like a pot of water, that's relevant to this application. Getting dressed can be really relevant as well, and that's everything from physical difficulties putting clothing on and off, but also sensory hypersensitivities to things like certain types of fabrics or clothing design choices. And lastly, there's a mental function section, and this is a really broad spectrum. It can be everything from intellectual and developmental disabilities, mental health conditions, and of course, brain fog, cognitive fatigue brought on by post-viral conditions. So those are all examples of the kinds of things the DTC will consider. So if you feel like you have limitations in some of those areas, I think you should strongly consider applying. And we know the process is confusing. The CRA doesn't produce a lot of guidance on how to fill out the application. So now I'd like to talk about how Disability Alliance Canada can help with these applications. We offer free one-on-one disability benefits navigation services on the Disability Tax Credit, Canada Disability Benefit, Registered Disability Savings Plan, Canada Pension Plan disabilities, and all other linked benefits and credits. We can work one-on-one over the phone or video conference, whatever is most convenient for you. Um, it's completely fine with us if you want to take calls from bed. Um, and we're happy to work with you to make the process as accessible as possible, whether that's offering time-limited appointments and um, potentially rescheduling a second appointment if not everything can be done in the time frame, just to avoid post-exertional malaise. And we can also work with someone on your behalf if a process like this, looking at a screen, is not accessible to you. Um, if you sign and allow us to correspond with someone else, we can work with someone who supports you, like a spouse, child, friend. For folks who are able to navigate devices well and look at screens for an extended period of time, we have online apps that help a person fill out the DTC independently in English and French, and they're linked in this slide. Um, this prepares a sample form for you to present to your doctor, and it's a really great resource if you are able to manage that independently. If you do have any questions or you want anyone to review that, though, we're always happy to help as advocates, and our services are completely free. Here are some ways to get in touch with us. The info email is just our general directory for help with the disability tax credit. It's the DTC Disability Alliance Canada.ca. And if you want to reach Eliza to ask questions about CPP disability, that's CPPD at disabilityalliancecanada.ca. I've also included our phone number if that's a better way for others to contact you, but I'm happy to leave this slide up so folks can take a photo of it or a screenshot, whatever is most convenient for them. And at this point, we're happy to take any questions.
Can I ask the first question?
Absolutely.
I think there's something that I've been saying that's wrong. It's not 3 times longer, it's twice longer. It must be PWD that's 3 times longer.
It's 3 times longer if it's only one impairment category. If someone is impaired across multiple areas, like let's say they have difficulty with walking and dressing and um, preparing food, if it takes that person 2 times as long to do all three of those things, they don't have to meet the 3 times as long. It can be 2 times, but if it's just walking, then it has to be 3 times.
So let me give people a tip on that, because the way to think about it is with these conditions, it takes you twice as long and you need to rest. So that's at least 3 times longer. And so the way that I fill it in, I say takes at least 3 times longer. And then I say often needs to break up the task with rest breaks, usually needs to rest afterwards, and often too symptomatic to do the task at all. Because that'll be important so that if you do have variation, and then I usually put in my forms, I put that on average, this patient is severely disabled in all activities of, and we only occasionally have to fight them, but we always win on appeal. So the other thing is if you lose, appeal, appeal, appeal.
Absolutely. Thank you, Rick. I completely agree. Some other helpful language to include in a disability tax credit application are the words substantially all the time. The CRA really likes to see those. And given that these are permanent conditions, the CRA is able to approve someone for the DTC indefinitely. And one thing that is important to write in those notes then is to say these conditions are severe, prolonged, and not expected to improve.
Thank you very much, Brooklyn and Dr. Arseneau. Before we go into the questions, just a small note. We don't have an official presentation for insurance companies just because they vary so much and the plans can be so different from employer to employer. But if there's any questions on short-term or long-term disability benefits as well,
Can I give a little advice on that since we're not going to talk about it?
yes.
So number one is they're not your friend. The job of the insurance company is how to figure out not to pay you. And so what you need to be careful is that they will tell you that you're insured for 2 years. That is a lie because at 2 years, long-term disability changes definition. And so to prepare for that, I suggest that you apply for Canada Pension Plan Disability right away. Because if you get that, it says that you're disabled from any occupation, which means that whenever you're fighting your change of definition, you have an ace in the back pocket by saying that you have already been deemed disabled from any occupation because the money goes to your insurer. So you might say, why don't they want their money? Because they want to try and kick you off. And so you know that you're not going to be kicked off anymore when your insurer asks you to get it, because it means they've given up on trying to kick you off. So make sure you apply for Canada Pension Plan at the same time as you apply for LTD.
Thank you, Rick. And also, based on my experience, I have 10 years experience in the insurance industry as a group benefits consultant. And I know from a lot of insurance companies, they keep this in the hush hush. I work with all the major insurance companies, and when someone applies for CCPD and they get a long-term disability benefit, they can't kick you out as long as you're under the CCPD umbrella, because then it looks bad on the insurance company to take benefits away for someone who's actually on disability considered under the federal government. So it's very important to apply for both. I know that it's very complex and it can take a lot of time. We're going to try to give you the resources, but try to apply for both. And if you have any questions on the insurance company's process, applications or anything, I would be more than happy to answer those ones as well.
I have something to add.
Yes.
If that's okay. Yeah, I just wanted to add in that I noticed someone in the chat asked a question similar to this. Is it unnecessary to apply for CPPD if you have good LTD? And I wanted to add in one more thing, which is that especially the younger you are, if you get on CPPD, then that will increase the amount of CPP that you receive when you're 65. Which is, and I could explain how this calculated. It's a little bit complicated, but it should increase, like especially if you're not working right now, then it'll increase the amount of CPP you receive at 65. So that's another benefit to getting on it earlier.
Also a note, and we will go into the official questions in a second, but a note on that question in particular. When you apply, if you already have your long-term disability benefit and then you apply for CCPD afterwards, the insurance companies have what they're called an all maximum benefit allowance. It's typically up to 80-ish% of the pre-disability benefit. And they will be deducting the amounts that you receive from CCPD from your long-term disability benefits. So they will start coordinating the benefits and the payments so that at the time you end up receiving the same amount, just from different sources, if that makes any sense. We will start with Dana, and we have a couple of questions on the chat, and we have some questions by email, but let's start with Dana, please.
Hi, thanks so much. I have been struggling my way through the whole CPPD application process cognitively, because most of my symptoms are neurocognitive. And after listening to Brooklyn's presentation, I'm now confused about whether or not I actually am eligible. So I want to know how I can get a definitive answer about eligibility before I push through.
Yeah, you are eligible because that's a medical decision. And
No, sorry. I mean, I'm talking about the minimum contribution, fulfilling minimum contribution criterion. Is there somewhere, like if I went to Service Canada in person, could they tell me before sorry, Dr. Arseneau, I'm with Dr. McKay. She's already submitted my medical report and all of that. I'm definitely eligible from that perspective. So I just want to see whether or not I'm wasting my time. I'm also getting much worse symptomatically as I go through this. So I don't want to continue if I have zero chance of getting CPPD.
Sorry, you said Brooklyn's presentation, did you mean, just so that I am clear, are you talking about the disability tax credit or about CPPD?
CPPD.
Okay, yes. So you're unsure if you have the contributions, you said?
Correct. I have my statement of contributions in front of me. The years that, like, I have the 4 out of 6 years, but I didn't know about the minimum contribution. I can't remember what the acronym was, M something something, $700 ish, whatever that was. So yeah, one of those years does not meet that threshold. So I'm just wondering how I can find out definitively before completing my application whether or not I'm eligible from that perspective. Does that make sense?
It does. If you reach out to us, I can, because I can't look at your, and I probably shouldn't look at your contributions in front of all these other people, but if you reach out to the email or the phone number on that slide, I could look at your contributions directly, and then I could tell you whether you have them or not.
Okay, I called the Alliance and they had like a 12-week waiting list. So I can circumvent that by emailing CPPD at Disability Alliance Canada.
Canada, yes. So
And
that 12 weeks.
That would come to you?
It would go to someone else who would send it directly to me.
Okay.
So yeah, our long wait list is for people in BC, but because Disability Alliance Canada is brand new, the wait list is much, 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 much shorter. So you would get help right away.
I'm confused with someone else then. Okay, from a BC-based nonprofit.
Yes.
Contacted.
It's the same. It's probably the same one. You're probably just thinking of Disability Alliance BC instead of Disability Alliance Canada.
Got it. Okay, thanks, Brooklyn.
Yes, you're very welcome.
Thank you so much. We got a question by email that says, beyond disability tax credit, can someone who is a homemaker and a stay-at-home parent qualify for other disability supports like RDSP and LTD through the spouse's company benefit?
So RDSP is through the disability tax credit, so you can absolutely access that benefit. There's also something called the Canada Disability Benefit, which is dependent on household income, but it's an extra $200 a month, and that's for anyone who is low income. You don't have to have had a work history. I would also encourage that person to look out for provincially administered disability benefits in their province, because those aren't dependent on prior income. It's just the federal income support CPPD that is. If anyone wants more information on the registered disability savings plan, I'd encourage them to reach out to Disability Alliance Canada or go to rdsp.com. One of our partner nonprofits, Plan Institute, administers that, and it's a great source for free and reliable information.
Thank you, Brooklyn. And in regards to the long-term disability through the spouse's company, unfortunately, that's not possible. Because the LTD, the insurance companies have what they call pooled benefits, and the long-term disability benefit is accessible only for the employee coverage. There may be some dependent life insurance attached to that particular plan, but unfortunately for disability, it only covers the employee in question. We have another question by email. Which terms or symptom descriptions should be avoided when discussing long COVID, POTS, ME/CFS, and fatigue to ensure claims are taken seriously?
So that's something I forgot to mention. That's a great question. Don't use long COVID. Use whatever diagnosis you have. So the only time I use long COVID is for WorkSafe BC, where we're saying that COVID caused the illness. But if you look at the definition for long COVID, you're going to have a really hard time to get approval for that. So if you have, because chronic fatigue has diagnostic criteria that are world recognized, et cetera, et cetera. So focus on the diagnoses that you have rather than the fact that it was caused by COVID.
And I can just add some things to not mention on a disability tax credit application. Don't mention your housekeeping capacity. For whatever reason, the CRA doesn't like to hear if you struggle to do chores. They think you have a higher level of functioning if those are the things you struggle with. I agree, it's ridiculous, but they don't like to hear about it. Don't mention whether you are able to drive. Don't mention your ability to maintain long-term romantic relationships. Don't mention if you are able to work part-time, even if you have a flexible employer. And oh, what else?
Well, you're thinking more information is not better because it gives them more things to nitpick. Pick the information that is the most relevant, the most salient, and the most hard hitting. So that's why when we fill out the form, even if the patient has 5 categories, we only fill 2. Why? Because it saves me time. And if you get rejected, I'll do the appeal. But it's more to save time. And so putting because patients often look at my friend, oh, can you include like these 5 pages? And like, it's not going to help. And it may get you in trouble if they can find something to nitpick or misinterpret.
Absolutely, Rick. I completely agree. And one thing we've noticed is if you have a few really strong sections and some that are weaker and may only qualify under cumulative effects, it's sometimes better to leave those off so the CRA agent doesn't perceive this as an application that's stretching to be eligible. Um, it's not fair. I mean, Eliza, do you want to jump in to say what you should not mention on a CPPD application?
Yeah, I feel like it's probably the same regardless of what your diagnosis is or what you're struggling with. You don't want to talk about your good days. A lot of people will say, yeah, I have bad days and yeah, I have good days. You definitely don't want to do that. You only want to talk about typical days and then elaborate on your bad days. You don't want to say anything that at all implies that you might get better, because if you get better, if there's any chance that you could get better, then they might want to send you back to work. Um, yeah, and honestly, I think those are kind of the two main ones.
So not only do you not mention things that are going to make you better, you explicitly mention this because this is what we learned. We get rejected. Go, oh, next time we'll do this. And one of the reasons for rejection was you have not exhausted all of the possible treatments for this illness. And so I have a copy paste that says treatment is not designed to or expected to bring about enough recovery for the patient to ever be gainfully employed. And so that kills that argument right on the spot. And so I would have your physician add that specifically.
That would
Thank
be
you,
a
Yes,
great
guys.
so
line.
go ahead.
Brooklyn, can you make me host whenever you have a chance,
Oh,
please? And let's take a
absolutely.
question from the chat. What advice would Dr. Ric Arseneau give regarding providing insurance company with doctor's updates when already receiving CCPD, DTC, and LTD benefits? They move to 6 to 12-month updates, so want to make sure my doc includes enough details so my benefits continue.
Don't worry about including enough details because if they're gonna try and cancel you, they're gonna try and cancel you. And so I'll give you an example. A woman doesn't leave her house for 3 years. She goes to a pancake breakfast. Ah, you left the house, you're canceled. And so we fought that. So the problem is that when I fill out the yearly things, I just have the patients come to a group medical visit and I say, ready to go back to work? Nope. And so I put no substantive improvement because to me, substantive improvements are going to go back to work. And I put the same information. So don't worry about putting the ups and downs because if you do, if they see an up, they're going to be all over that like a bear on a beehive to try and get you to go back to work. So it's always no substantive improvement. That's the answer. And then whenever they put housebound in your forms or bedbound or ambulatory, you click all 3. And then, like I said, these forms are not designed to capture it. So you fix them to capture your disability. So you put ambulatory, and then on top of bedbound, you'll put often, and then on top of housebound, you'll put mostly. And so that you're able to more finely distinguish. But more information is not better.
Thank you, Rick. Let's take one of the hands up. Emily, go ahead.
Hi, Dr. Rick. I'm one of your patients. And I mean, you're a life-saving person, so I have you here right now. I have a question. You signed my CPPD on March 3rd, and I'm just finishing doing my own portion of it because it's taking me long due to cognitive exertion, obviously.
That's fine.
I have a question about when I'm supposed to say that I stopped working. So they have like two little things I have to put in there. What do you think I should put? Because technically I stopped working for full time in 2024, but in 2025 is when I like straight up could not work at all anymore. So what do I put?
I think that's a better question for Eliza because it's really hard to capture. I was off for a while and then I went back to work because for me, that would mean you didn't qualify for that period. And it's from the last time you worked, but this is where Eliza would be the expert.
Okay,
Yeah,
thanks.
I would say that if your MQP allows it, I would go for the later date, the date that you actually stopped working for good.
Okay, yeah, because 2024 was sort of part-time. Like it wasn't very much, but I think I'm in that eligibility, so I'll write
For sure.
2025 then. Okay, thank you.
And you're welcome. And for other people, if your MQP doesn't allow it and you have to put the earlier date, then there are some workarounds for that too, where you can add in something about that being like a work trial that failed and yeah, argue that you tried to go back to work and that was proof that you weren't able to. But in your case, when it's within your MQP, it definitely feels like you can just pick the later date.
Okay, thank you so much.
You're very welcome.
Thank you, Emily. We have another question by email. How can patients accurately present their situation to maintain support without being disqualified for lack of improvement?
Yeah, that's a tough question because I don't think you would be disqualified for lack of improvement because these are chronic complex conditions. And when I write my notes, I focus on the worst possible outcome. And that's why you have to warn patients because they're like, "Oh my God, I read your note and it sounds horrible." Yeah, but that's not for you. That we because the from the insurance company and from a medical legal perspective, it's more likely than not, and that means 51%. And so when you say you're likely disabled indefinitely, it only has to be 51% from a medical legal perspective. And so you don't have to worry about going up and down. That if you say that you're stable and that's why saying that you're getting worse is not going to help. So I don't even say that.
Thank you so much, Rick. Um, I have a question for Rick. If I have abnormal lab results, for example, possible viral reactivation, is that classified as PCC or long COVID PVS?
So
Regarding documentation to what to put.
so nobody knows because it may actually not be viral reactivation. Because what happens is your immune system is really smart and it clips part of the virus and it holds on to them to make copies later. And whenever you do the testing for the blood, it says, oh, look, there's a virus there. But no, it's actually your immune cells holding viral markers. And so the meaning of the positive tests, the implications for the illness, nobody knows for sure.
Thank you, Rick. Leslie, you have your hand up. Go ahead, please.
Sorry, I'm just like trying to find unmute. Okay, so mine's kind of really long and convoluted, so I'm going to try and shorten it. I've applied twice through my doctor for disability tax credit. Um, they focused on the fact that I had lots of eye operations at the same time and they denied. And then we said, no, no, long COVID. And I know the doctor is now saying, don't say long COVID, say all the other stuff. She found you, Doctor. Is it Generu? I can't say your name. I'm French too, but she told me to go on to this seminar and listen. So this is great, great advice, but she can't seem to just write all the right things. And then on top of that, I just got a new diagnosis from my dentist called lichus planus, which means my white blood cells in my mouth are attacking each other. I don't know what that means, but it's
Yeah.
a new, I think maybe that might help me, right?
No,
I don't know.
lichen planus won't help you.
No.
And
Okay.
it'll give them something to nitpick. And that's why
Okay.
when I tell you my patients have 5 or 6 central sensitivity syndromes, I just put 2 diagnoses on the forms.
So what
The
do I
two,
put then?
the 2 most disabling ones.
Like I'm
Because
chronic pain, sick, sick, sick.
yeah, so if you
So
have chronic pain, do you fulfill criteria for fibromyalgia? And if you have fibromyalgia, that 70 to 90% of patients with fibromyalgia have chronic fatigue syndrome.
Yes.
So I would go to that page on our website and download the diagnostic criteria, bring it to your GP so you don't have to say long COVID and you don't, because it's almost like what was said earlier by Brooklyn, is that if you look like you're padding your application with extra diagnoses that are not
Yeah.
relevant, that so lichen planus is not going to help. So focus on your top two. And that's what I was talking about before. If you don't have a diagnosis, it's really hard because a symptom they're more likely to reject than if you can put that symptom in the context of a hard diagnosis that they can wrap their head around.
Okay. And can you keep applying? Like if they keep saying no 3, 4, or 5 times? Like
Yeah.
I'm very it's 4.5 years I've had it now. It's getting funny now. At this point I'm
Where do you live, Leslie?
Toronto.
Toronto. Okay. Yeah, because I would download the diagnostic criteria,
Mm-hmm.
reapply,
Mm-hmm.
and then, it's often not worth it for disability tax credit, but for patients, I have done uh, what are called independent medical evaluations for patients who live in Quebec and in Ontario, and I've won all of those. Uh,
Oh, cool.
but it's a pain in the ass, and it's a formal medical legal report. It's not like a note that I write for my patients, so it's a lot more involved, and it's probably wouldn't be worth it for disability tax credit.
Okay. Well,
Let's
I'll just keep trying. Thank
Can
you.
I jump in here, Leslie?
Yeah.
So I offer one-on-one disability tax credit support. So I could go through with you your most recent
Awesome.
application
Awesome.
and go through what the issues were. And you can submit something that's actually a little less involved than a new application if it was done within the last year, which is a
Yes.
consideration to the CRA.
Okay.
And we could help you prepare materials for your doctor to review and sign based on our expertise in what we know has been successful in the past.
Thank you so much, Brooklyn. Awesome. Thank
All
you.
right. I will private message you our DTC general inbox email
Yeah.
and we can connect later this week.
Awesome. I'm so excited. Thank you, guys. Thank you.
Hope you're muted.
Yes, sorry. I know we're over time. Are you guys okay if we can answer just a couple more questions?
I'm happy to stay as long as.
Absolutely.
Thank you. We have another question by email. Which specific policy terms define when an employer may terminate employment due to lack of fitness for work? Hmm.
That's a real tough question because that's like almost a more legal question than a medical question. And that's the only time that we lose is if it's a technicality that's non-medical, like this was pre-existing condition and they have evidence of that, or you didn't pay in long enough, or your LTD only kicked in at a year and you were there for 8 months. Those are the only times that we lose is with the technical issues. And this sounds like more a technical thing than a medical thing. Maybe Brooklyn or Eliza can help.
Yeah, so funny story. I'm not practicing now, but I'm actually qualified as a lawyer in British Columbia. Depending on the province you're based in, I would strongly recommend reaching out to a free legal clinic. Most law schools across the country offer some sort of pro bono legal support. They often review employment law cases, and many places also have a pro bono organization. I believe there's Access Pro Bono in BC and analogous organizations in Ontario that can offer free one-time consultations just to explain the law and explain your situation. So if you're looking for free support, I'd strongly recommend reaching out to law student legal advice programs and pro bono programs regarding employment law.
And if you live in British Columbia, go to our YouTube channel and watch the presentation by Whitney Derber, who's a patient. She and her partner Susan will do your initial first meeting for free, and they'll tell you whether or not it's worth pursuing. And so you could also reach out to them. Whitney and I have been to court a number of times together. We always win. Yay. And she's also not just a good lawyer, but she's a wonderful person.
Thank you so much, guys. Question from the chat. This may be too specific of a question for this format, but regarding the CPPD, would there be any provision in that four of 6 years thing for people who went back to school? My case worked full-time until 2022, COVID in late 2022, school full-time from 22 to 25, but was slowly less able to participate as my condition worsened. Became officially disabled in 2025, but retroactive to 2024.
Unfortunately, no, there is no provision for going back to school. So yeah, if you look at your statement of contributions and determine your MQP, in your case, yeah, if you haven't worked since 2022 and it was full time, then it probably won't be anywhere past 2024. Actually, that depends now that I'm thinking about that, because if you would have had the contributions in 2022 back 4 years, then by 2024 you might be able to get your MQP to December 2024. So it's less about when it's like official and more when your doctor can agree that that was when it started. So you might be right on the line there, but to answer your actual question, there isn't a provision for school. Yeah.
Thanks, Eliza.
Yes.
Question for Ric. Do you have a list of doctors in Alberta that would be of the same mindset as yourself?
I don't, yes, unfortunately, we don't know.
We wish there were more of you, Ric. Another question in the chat. I was diagnosed with ME in 2016 and went back to school to try for a second career. I was unable to finish my PhD and my supervisors arranged for me to master's out last year. How would one situate the attempt to change careers in hope of not having to retire but failing at that?
Again, a technical
Sorry.
question.
Actually, that's my question. Because of lab work and TA work and etc., I do have CPP, so I'll fit that. The question is more being diagnosed and not applying for the CPPD at the time because I couldn't admit I was disabled, so went back to school. Sorry. Unfortunately, this is actually a good one for everybody. If you are one of the ones who has the emotional dysregulation where you'll cry at the drop of a hat or something, put that in because it makes interpersonal very difficult. So I'm actually not sad. I just cry all the time now. Anyway, there was paid employment, but it's been now 10 years since I was diagnosed. So when I apply for the CPPD, they may say your original diagnosis was this date. You know, part of it is rest wasn't, there's not a lot of sports in Ontario, and my diagnosing doctor was so overburdened. It took nearly 2 years to actually get in to see her. So I didn't understand the level of rest I needed. So I worked myself into being unable to work. So how does one get that across?
I'm having trouble answering your specific question about getting that across, because I think it really just comes down to like when your doctor will say that you became unable to work, and whether that fits into your contributions or not. And if you do reach out to Disability Alliance Canada and would like us to help you with that, then I could look into your case more in depth, getting to look at your statement of contributions. And one thing that we also do is we're able to call and talk to your doctor and even give them like a little draft for the medical report. And some doctors will just like be lazy in a good way where they'll just copy exactly what we write, and others will fight us more. But we can help you work with your doctor on that and look
Great.
into it and see if this would work with you. Yeah.
My family doctor is phenomenal. She is just so good. I'm very lucky. So thank you for that. I will reach out.
That is
Everybody
wonderful.
who's struggling with resources, our website has tons of stuff. We have 50 videos that explain various aspects of these conditions, and we also have medication handouts. We've got a whole bunch of stuff that, interestingly, when I look at our statistics, that 60% of the people who look at our website are outside of Canada. And if you go to our YouTube channel, it'll say selected for new patients, but we also have channels on dysautonomia, on pain, on MCAS. And today, after my presentation, we will actually be the first clinic in Canada that offers comprehensive care for pediatrics, teens, and kids with these conditions.
Thank you, Ric. One last question before we go, and if you guys have any more questions, just raise your hand. But one last question from the email. Are there any navigator professions or organizations that help evaluate functionality and identify appropriate resources?
Depends on what you mean by organizations. So, for instance, and unfortunately, and this is a truth, is that long COVID, post-viral syndromes are a disease for the privileged. And what I mean by that is if you don't have to worry about financially, check. If you can hire a housekeeper, check. If you can hire a nanny, check. If you can hire a dog walker, check. If you can afford the things that are not covered, check. And so a lot of our clinic is focused on being able to provide all these services for patients who can't finance them themselves. And so everything in our clinic is covered, but the people who do work in our clinic also have a private practice. So if you wanted to work with an occupational therapist or a physiotherapist or a dietitian or a naturopath, all the people who work with us also have private practice. But again, that's an answer for somebody who's privileged and can afford it.
Thank you so much, Ric. And with that, we close the webinar for today. Thank you so very much for attending, everyone, to Ric Arseneau for being here, and Disability Alliance Canada as well for providing such valuable information. And if there's anything else that you guys need, feel free to email us at loancovid@covidsociety.ca, and we'll see you guys at the next session. Thank you so very much and have a very tolerable rest of the day. Thank you.